Good afternoon, everybody. As Clive promised, there will be interactive session, so I should stick to the rule. There will be a very short presentation. I really wanted to remind us a few developments in the Commission in the last year. Is it something Commissioner already mentioned during his speech? The agenda for the healthcare system we developed last spring. I should say spring before, because it was 2014. We are already in the summertime. So this time when we try to assess, also reflecting, as Commissioner said, the discussion in Vilnius, what is really possible to do for us as a European Commission, European level. So we came to this kind of architecture. So we defined this in the three boxes: strengthening effectiveness, increasing accessibility, improving resilience. In the first box, we put the health system performance assessment. This was already mentioned a few times, and you referred to this as an interesting tool, to help with the measurement and agreed way of doing things. I am co-chairing with the Swedish colleague Olivia Wincel this expert group. And it's very difficult and complex work, not just because it's a relatively new tool for many member states, but also the science or the knowledge around this still is developed. So we have to see the results, be patient for the results. We are targeting the first bit of work around the quality of healthcare, the second one around the integrated healthcare. The first results, you can of course watch this through the different publications or information on our website, but the complex first project we hope to finish by beginning of next year. So then patient safety and quality of healthcare. This is quite good already work on this front. And we'll continue. We just revise our approach for this and looking for the next opening in few weeks. Integration of healthcare, again, easy to say, difficult to measure, but let's see what we can discuss as well today. The second, accessibility. This is the box, which we are also quite busy planning of EU health workforces. It's quite a unique exercise, which I go back to the history, because sometimes it's also good to say what we have done so far. I mean, when we started Green Paper in 2008, 2009, European Union was really focusing only on the recognition of qualification. I mean, this was not much, interest on our level to do planning or be engaged in the EU workforce development. It came because first the 2004 accession showed that for many countries mobility of professionals become not just as a problem for recognition of diploma, but simply the problem to be solved. And many countries force Commission or invite Commission to do more on this front. Especially new member states, but also those countries receiving workforces also wanted to be more involved in this. Cost effectiveness of youth medicine is an issue we will most probably discuss in this panel as well a lot. And finally, implementation of cross-border directive. Cross-border directive for me was, and I think for the European history, was one of the important trigger of our interest and also ability to do work in the healthcare systems. Before, European Commission was relatively not involved in this field, but directive really negotiations showed that how important this sector is and what we have to do. The second trigger was linked to the financial crisis, when basically we went through the European semester exercise, and I think it also showed the interesting development. And then improving resilience. I mean, this name was given, following the development in WHO, in other international fora. It's very interesting. When we first time introduced in the paper, many people ask, what you are talking about. But now I think after a year, this is more frequently used. But what was interesting for us when we developed this part of or this communication was to really see, how European Union can find, the place in this field, and so we defined three areas. HTA, health information system, is a big issue which we hope to develop in next few years, and finally e-health, which already was discussed today. And of course, when we go to the question of access to healthcare, which is coming out of this communication, we believe we can focus on a number of issues, but again, this is something we may discuss in this panel about the definitions we are using, and then how we really measure this. In the previous panel, we hear some concepts, but this is how we see so far. In one hand, it's important to see the health insurance coverage, or basically the coverage in the population, because if you have the national system, is usually 100%. But of course, share of population, what is under coverage, basket of care, and so we call this depth of coverage. It's very interesting because the basket of care. This discussion was also triggered in many countries by cross-border directive, because cross-border directive asked member states to define the basket of services for patients that would like to go, because they will get only treatment which is available in their own country. And of course, it's triggered interesting question how you can develop this in a number of places. And then it was already discussed affordability of healthcare, including co-payment, cost sharing, and finally availability, distance, and waiting times. We try to learn more from studies we are doing through Eurostat, and this is the survey, this analysis done by my colleagues. The survey reported unmet needs for medical examination by detailed reasons. There are response for 2013, and you can see how different. So basically, for those you are not able to read, green is waiting list, red too far for travel, and finally blue too expensive. And you can see how differently people see this in different countries. In some countries like Finland, they see this waiting is dominating the problem. In Latvia, the country we are here today, simply the cost is a driver. But also you see how different people perceive this. And finally, we strongly support the stakeholders partnership, which was introduced today in the morning. So we are very close contact with this. We are helping with the opinion of expert panel, which, by the way, is also interesting tool. It was born relatively new tool for European Commission to work with. Just remind us, the expert panel was triggered by during the Hungarian presidency, when ministers say, okay, let's try to form the expert group on the level in the Commission and try to help solve number of interesting questions. And this panel is dealing number of interesting questions, 12 wise men and women, and both from public health and economic field, almost equal, which is very interesting also to see dynamic in this panel, because of course they're approaching the areas from completely different points of view. Finally, we got additional resources from the European Parliament to do the so-called pilot project, access to healthcare in the rural areas. So this will help us, to maybe maintain the momentum, but I would be very happy to discuss with you what we can do, what we have to do, and how we can do.
Excellent. Thank you, Andrzej, and that was very succinct as well. Now, if we have some friends with microphones, after each speaker's introduction, if there are just any points of clarification that anybody would like, I'll give you the opportunity to come in now. If anybody just saw anything there you'd like Andrzej just to provide. Everybody's all absolutely clear. I can test you on this in a few minutes. All happy? Okay. In that case, Guido, can we then move on to you, please? And we very much welcome your perspective from your background, please.
Thank you very much, Clive. I think today many aspects has been addressed about the development, about an accessible health system, about the public health, equitable access, so far, and has been examined by many standpoints and in a more holistic view. As you might expect, I will be focusing a little more on a specific issue, which is basically the equitable, we can define equitable access to innovative medicine. And of course, I will take mostly what can be and what is and what might be in the future, the contribution of the regulators, of course. First, we have to shortly define what we mean by innovative medicine. I think an innovative medicine today has to address an unmet medical need and has to provide an added value. And when we talk about added value, unfortunately, we have to bring in the price, the cost. The added value comes at a cost. And even if EMA is not meant to intervene in any economic consideration in any of these aspects, still we have and we should have the concern about assessing the medicine that nobody can afford. So with this concern in mind, we are exploring together with the Commission, with many other stakeholders, what could be our contribution, what can we do in our leader remit to help overcoming this problem. I think basically EMA, without changing the role, without stepping in nobody else's remit, is ready to support basically with two actions. We have to remind that what is the divergent point that is coming more and more divergent? We, as opposite to the payers and HTA, we rely on different evidentiary standards. We basically are addressing the benefit risk. Meanwhile, the other community is addressing the effectiveness. And this is bringing, as I say, the two diverging set of evidence. So what we want to do is to foster and to support and to feed with information, with the data that the Commissioner today mentioned. We sit on a lot of data, and in future we will sit on even more data than we have now. Well, we are ready to contribute, to feed with those data, with those information, whoever might need, national authorities, other bodies, the Commission, the decision makers, the policy makers, everyone that we might help in this. So we have two specific actions. One is the early dialogue. We already addressed in the previous section the early dialogue, the added value of the early dialogue. There are many things to be defined about the early dialogue, but still I think it's tremendous, importantly, building blocks. It's not the solution, but it's the foundation for the interaction with the stakeholder and the integration of these two evidentiary standards that should come to a common understanding, a common planning, a generation of a unique set of evidence, the needed evidence. And the second is the planned monitoring. So basically, on the early dialogue, we understand that as early as we can start to identify what are each one need of evidence to be generated, that will generate a lot of benefit for the patient, who will probably access much early the needed new option, for the investors, because the investor might have, as of the beginning, the full picture of what they have to generate if they want to eventually not only to access the market, but not only to get the authorization, but in fact to access the market. For the patient, there is, of course, less exposure to trials, which I think is tremendously important. If we plan ahead together, we go in parallel, we don't go in sequence, and we probably generate with the same design, with the same trial, with a different design, less patient, more data. That's, I think, is tremendously important to start this dialogue very, very early. HTA and payers might benefit because they can expect what evidence they will be provided to take their decision. And that is tremendously important because they can steer the process as of the beginning, not to step in after 10 years. This, I think, is an incredible added value. The other aspect is the planned monitoring. Now we know that the most of the innovation will come from the personalized approach for the very innovative medicine generated by a completely new science, a new technology. That's make the randomized clinical trial one of the options, not anymore the only option. What this mean? This means that we have to move probably from the uncertainty of the prediction that the clinical trial, the randomized clinical trial is providing, to the more robustness of the monitoring, the early monitoring, which means that we have to plan the post-marketing much ahead. We now have the tool. We have the post-authorization studies, both safety and efficacy, which means that we can plan those together with other stakeholders, patients, payers, and we have to share the data we generate from that with them and industry. That will benefit all. Patient will experience a higher level of safety because we know now that in the real world, what we generate in terms of safety and in terms of performance of the medicine will take 10 to 15 years. If we plan this ahead, we can have much earlier, much efficiently, much precise data about the performance in the real life of a new medicine. Not to say the opportunities for the investors. They can start to generate revenue much earlier in a more predictable way. And for HTA and payer, they can have much earlier the real performance in the real life and give them the opportunity to start reflecting a new pricing approach that is beyond me, and I will not mention anymore this word today. I did already twice, and I think it's too much. In a nutshell, this is more or less the line that we are heading with the adaptive pathway. To make it happen, we need all the stakeholders to brought together, to integrate. And in this respect, I think the European Commission is doing a terrific work with the stamp, because they are exactly trying to put member states and all the stakeholders reasoning if this is the approach, if we have better one, and to evaluate eventually the first outcome of the pilot. You asked me before the start of this session, what could be done? What could be the proposal? Well, I have one. I think I'm a strong believer of the learning by doing. And I have a lot of confidence in initiatives like the one that Belgium and Netherlands are bringing together all across the four next presidency, just to cluster spontaneously, voluntarily, around some specific problem. I don't think we are ready for having a new agency, a new remit of our agency, a new body to take care of the price reimbursement and effectiveness, HTA in a holistic way in Europe. But I strongly believe that if we have initiative like this, to cluster with a variable composition of the cluster addressing different issues, I think this will generate some possible solution for different problems. With a negative example, negative in the sense Why we cannot do for ACV, for example? Because the prevalence across the Europe is so different that we have experienced there is no interest in clustering altogether around this. But it might be for some orphan disease where the prevalence is much more homogeneous. That might really generate some interesting voluntary exercise. That's it.
Excellent. Thank you, Guido. Okay, thank you very much. And thank you for also picking up my challenge on some examples of positive ways forward. Again, are there any questions of clarification that anybody would like on what Guido has introduced there? Can I just pick up a couple of things, Guido? And forgive me, it's not my field of expertise, but in the general context of where we're trying to get to in this event, I think what you just pulled out an example is good in the positive sense, but how do you build in an understanding of the equity factor? If you have a clustering and you have some states going faster than others, how do you include monitoring of how that is equitable and the impact on inequalities?
Well, as I said, I think we need examples in the real life. Let's assume that a negotiation for some upcoming high value, high clinical value, but high cost new drug. Many countries have different approach to cope with that. But some countries have a common problem, a small market, my experience, common problem. They might benefit of having a common approach, and the company can be very, very keen to have a way to negotiate something to access a market where it's more difficult and where they have no developed tool to cope with. As I said, we have to learn by doing. Maybe it's not the right approach, but so far I really appreciate the initiative that Belgium and Netherlands put together, because that means that there is a sort of aggregation, and of course we have to see the results.
Very good, very interesting. Thank you very much. And those of us working with older people as well know that the European Innovation Partnership has this approach of stimulating learning by doing and clusters initiatives too. So it's an interesting example. Thank you. Monika, let's keep you back no longer. Can we bring you in? And let's hear from Monika, and then I'll bring in some questions generally, if you would please. So Monika, from your perspective now with the WHO, could you share your initial thoughts on this subject?
Thank you very much, Clive, and thank you to the previous speakers for a very interesting and comprehensive discussion. I'm going to give you a little bit of an introduction to the context of how this is organised and taken forward in the WHO European Office. So I mentioned already this morning briefly the European strategy and policy framework for the European region, which is called Health 2020. And this forms the framework and the basis of all of the work that is ongoing in a moment, including the work on health systems and access to health care. And the two underpinning values that I want for us to retain in this discussion, which form the basis of Health 2020, but also form the basis of what we're talking about, are equity, which we've already mentioned, and this is a particularly important issue when we're talking about accessibility, but also health as a human right, and this is a rights-based discussion when we're talking about access to healthcare, when we're talking about individuals' access to health and well-being. So in that context, Health 2020 has 4 pillars, and apologise to all of you who have already heard this and know this, which I'm sure is everybody. You can I'm sure quote this back at me. But the Health 2020 strategy was adopted in September 2012, and it has 4 pillars which are addressed within it. The first is health throughout the life course. The second is tackling Europe's biggest challenges, both non-communicable and communicable. The third is building people-centered health systems and strengthening public health capacities. And the fourth is creating resilient communities and supportive environments. And the issue of accessibility to health and healthcare is a core component of those four. And in order to deliver those four, there are two strategic objectives within Health 2020 without which it's not possible. The first one is to tackle the huge burden of inequalities within our region. It is our greatest shame within Europe. The addressing of inequities is a priority for us all. It must be. And the second is strengthening governance and leadership for health. So these two strategic objectives are those that inform the other pillars. And I mention them particularly because my own program of area where I work is on the governance for health, on the second strategic objective there. But going into the people-centered health systems and strengthening public health capacities and services, I mean, just an observation, when we talk about access to health services, that also includes, of course, access to public health services and health promotion and disease prevention. But from the WHO side, we have two main components within this part of our work. The first one is transforming health systems, which I'll go to in a little bit more detail. The second is universal health coverage. And by that, explicitly within the European region, we're talking about a Europe free of out-of-pocket expenditure. And when we saw the unmet needs slides from Andrzej and the Commission, we saw the level of reporting, self-reporting that's coming back saying that people are not accessing the healthcare that they need because it is too expensive, because it is beyond their reach. And this is something which is difficult. It's difficult in Europe today that we have a population that's facing poverty, that's facing impoverishment due to their health needs, and it's something which we've all accepted is not an acceptable situation. So within those two, transforming health systems, the priorities that we're looking at is empowering and engaging people. And we discussed it already this morning, the importance of the people at the centres of our health system in order to make some of these changes. The second is the comprehensive service continuum. So this is the breadth and the depth that Andrzej was talking about. The third is the new models of care. We talked about innovation in medicines, but of course it's also about innovation in care, innovation in practice, innovation in education, and also innovation again in the area that I work in the integrated approach, the governmental approach, but also society approach to the issues that we're talking about. And four is quality improvement. And within Europe, free of out-of-pocket expenditure or universal health coverage, we need to look at policies that reduce out-of-pocket expenditure, both within the health system and also beyond it. We need to look at adequate public financing for the services that we have and that we need. We need to look at the fragmentation of some of our funding and the strategic purchasing, including in the areas of medicine. And there are some underlying components into these. We have issues around workforce, we have issues of management and pricing of medicines, we have questions of information, we have a complexity in solutions, so local solutions and cultural context. And just two final points before I'll stop. The systems component of what we've been talking about, and we mentioned this already, the accountability component of the systems component. The incentives within our system for some of the issues that we're dealing with, the competences, the communications element of what we're talking about. Innovation we've already mentioned to a certain extent, but again, we're talking about innovation in different areas of the system. And in addressing what we're really looking at in terms of change, we of course cannot forget the leadership and the management components of both. And I think I'll stop there.
Excellent. Thank you very much indeed, Monika. That's great. A lot of important points. Any questions for Monika at all? Yes, please. If we can get a microphone to the man in the middle, please. And I think I turned my back on somebody prematurely before. Was there anybody over here who wanted to ask a question? I'm quite happy to take that question now, and then we'll move on to the slides. I'd like to get you voting as well. So let's bring in some questions. Yes, please, sir.
Good afternoon, everyone. I'm Matthew Attard. I'm the Secretary for the Epilepsy Association of Malta. I'd like to press a point, and which I didn't have time to ask earlier on because there wasn't enough time for questions, but like to take this opportunity to ask to you, because you represent the health organization, and since you mentioned poverty and some unacceptable situations, it was interesting because there was a gentleman on the panel who gave a presentation that the health system in Romania was interesting. However, he failed to mention the organ trade, and I'd like to ask you, what practical measures does the World Health Organization have to actually stop that? Because it's not being done in the streets. It's being done in private hospitals, and it's being done specifically, as you said, due to poverty, especially now during the financial crisis. That's just one point I'd like to ask you. Thank you.
Thank you. To give Monika a chance to think about that, can I have a microphone for the man with the white shirt and the mustard tie, and then for another man in a white shirt, and a woman?
I just wanted some clarification from Guido Rasi. I'm Paul Corns, I'm an oncologist, and I co-steer the European School of Oncology's Access to Innovation Working Party. The implication of building cost-effective assessment early into the assessment of a drug, and you said that could choke off or bring in investment on the way, just worries me. Will the implication be that some drugs will be choked off in development because they don't make cost-effectiveness targets? I'm just thinking that we often don't discover the value of a drug until many years after it's licensed. The biggest success in oncology research this year has been that a very old, firstly expensive, now cheap drug, docetaxel, given early to men with prostate cancer, buys them 2 extra years of life at an extremely low cost. And we've only discovered that now it's an off-patent generic drug. And I'm very worried that a focus of value early, which I approve of, I'm just worried you said it would then act on investment of that drug development.
Okay, thank you very much. Again, I'll bring you all in, give you all a chance to comment on these questions. There's a man down the front there. 100 hands now.
I would like to ask for clarification about terms. Traditionally, we had this universal coverage. In Vilnius Declaration, we have universal access. Now we have universal health. So just maybe you can elaborate a bit what are the main, let us say, points, and maybe some more universal things we have. So
Okay.
how long this list will go? Thank you.
Definitions, that's fair enough. Woman at the back, I think, was the next person with a hand up. Please. There's a woman over there in a mauvey, pinky, lilac-y top of some sort, and there's a man at the back, and another woman there, and then I'm going to stop after all those hands that I've seen at the moment. Okay.
I'm Alexandra Georgieva. I work at Politico. I'm reporting on health. I have a couple of questions. The first one is to Monika. I would like to ask you, there was a report that was done in March on the prices of and access to medicines, and since that didn't really reverberate much in Brussels, I was wondering, are you planning to organize any events or anything that you would like to raise awareness of what you found in the report? And also for Andrzej Rys, sorry mispronouncing your name, I'm really bad at this. I would like to ask about your cooperation with the patient group that I've mentioned before, and there was the Latvian minister earlier who said that in Latvia especially, patient groups are not necessarily considered, how to put it diplomatically, in a very positive light because of their funding. I was wondering, is there anything that you would consider, any problem that might come out of this, or any considerations about your involvement with the patient groups, and also having in mind that similar things were discussed in Brussels level with the alcohol health and alcohol forum. So thank you very much.
Thank you very much for the questions. Yes, please. Yep.
Good afternoon, everyone. My name is Cornelia. I'm from IFMSA, the International Federation of Medical Student Associations. Thank you for the panelists, for the wonderful talks. I wanted to touch, as a medical student, of course, as a future healthcare professional, I briefly wanted to touch the topic of workforce. You have touched it briefly in the talks, and it was mentioned previously, but usually it has been just lightly touched and not elaborated as such. And if you take the global context, for example, if we look at May in Geneva, there was a lot of times mentioned there is no healthcare without healthcare workers. And it's quite an issue in a lot of countries, the workforce planning, talking about from the medical education side up to the planning about doctors in rural areas and as such. And in Europe is also a very, very hot topic, I believe. I would just like to ask all the panelists, what do you think could be the solutions? I mean, is there something happening right now in terms of this problem, and what could be the solutions in the future that has to be taken right now?
Okay, thank you very much for that. And panelists, we are going to flash up a question in a short time about health workforce, so I'll give you a chance to think about that and ask that one. Two speakers at the back there, a man in a light blue shirt and a woman next in a very nice shade of green that I can't describe.
My name is Peter, I'm a board member of EFA, and I would like to have the definition of universal access. I would like to really like to know what it means, for whom, what does it mean for migrants in Europe, what does it mean for undocumented migrants in Europe, what does it mean for prisoners? If a prisoner is hepatitis C, what does it mean, universal access? Would he get the new medication? How much would it cost? So please be, in your answer, very specific.
I can't promise that the speakers are going to be able to give you definitive answers on all these tremendous questions, but we'll do our best. Please, last question.
Hi, I'm also interested in some specifics. Aoife Gallagher from Eli Lilly and Company. Monika, you talked to the two work streams of your current work at the moment, one around transforming health systems. I was wondering if you could talk to some examples that the WHO has identified of best practice in innovation in care and innovation in practice. That was one work stream that you mentioned, and I'd love to hear a specific to kind of inspire us here today. Thanks.
Thank you. Monika, are you able to lead off? I'll give each of you a chance to pick the questions that are directly addressed to you. Okay. But there were a couple there, organs, and that particular last question as well. Would you like to respond?
And actually, I did, one thing that I forgot to qualify in my introduction is that the person who was supposed to be here is my Director of Health Systems, Hans Kluger. So I'm actually in a different work area, and I'm stepping in for him and the presentation. So unfortunately, I'm not yet fully informed on some of the issues that you raised, but I'm happy to pick that up afterwards and respond to questions as they emerge.
That's absolutely fine. Perhaps I'll flash a slide in a couple of minutes where you might all want to say something about definitions and where we are, which came up in the last session too. Guido, I think it was at least one specific question for you.
Yes, I think it's a very important question. The idea of the early dialogue is basically meant to give a joint advice mostly to those more inexperienced producers like SME, spin-off, academia, who, and is meant to address basically the high attrition rate in the early phase. Our fear is that we have a lot of very good products that fail because of, let's call, regulatory ignorance. And that exposes patients and then they cause a lot of inefficiency in the system. With this approach, we hope to inform much better on a specific basis, on a product base, one by one, the concerned people. This is at least the aim. Of course, there are some side effects, and I'm very, very happy to start to work and to mitigate. It can be that we can generate some side effects. I do not expect that the major company who is already have a robust planning behind will be stopped by things like that. It's just a matter of generating different or more data. However, we can explore what are the limits of this and to as of the beginning, to try to mitigate. Overall, we expect that if we will be able to demonstrate a decrease in research and development costs, the payer will be able to negotiate better eventually. That is beyond us. Okay, but thank you. The question is very, very important.
Thank you very much. Andrzej, a couple of questions I think were specific within your remit.
Yeah, I will start from workforces, since my favorite topic, one of my favorite topics, is difficult choose. But as I mentioned, this was quite interesting journey for my team and for European Commission. In the beginning, this was really seen as a only issue concerning the recognition of diploma. So doctors travel from country to country, or pharmacists or nurse, and get recognition, can work and so on. But of course, the phenomena, the world changed completely, and people started to move much more frequently than before. There are professional opportunities, there are of course the economic driver as well, especially east to west, but also west to west, if I make use example of doctors or nurses traveling from UK or Germany to United States or Australia. So this movement is also to be watched by global kind of monitoring, which we try to do together with OECD and WHO. But coming back to the action, because I think this is what we would like to get out of this meeting. Just this week, last week, I met with my team and also the leader of General Action, which is now in the workforce planning, and we discussed, what would be next, because we are gathering so much evidence and so much interesting guidelines that maybe it's good time for most probably next year to have more political reflection. What basically we have now, because the picture is very dynamic. Just mentioned, 4 or 5 different drivers. It's clear for most of countries that doctors don't like to work in the rural area. And this is not an easy solution, It's the time when NHS said, every services will be available, on the geographic distance, and you see doctor, in Ireland, in Scotland, and the services were there. It's ended because doctors are simply more free. They have more offer. They are more decided. Since we discussed gender factor today in this room, but also, of course, the feminization of profession is a fact. In many countries, you see this as also as an important driver for change. In the previous version of this profession, people were asked to work 24 hours, 7 days a week. Now women would like to have family life and time for children and so on. So of course you need to see this also as a benefit of this and also kind of problem for the planning. But it's a fact. The other driver, of course, is the question about the aging profession. In a number of countries, in both doctors and nurses and other professions, the population of doctors and nurses is aging, faster than the general population. So of course you will find very soon the shortages of professions, and so on, so on. Maybe last point, which is maybe the most difficult in a number of countries, the skill mix. What should be done by doctor, by nurse, by pharmacist. Can we move some skills between those professions? It's a very sensitive issue, and just example. Can pharmacists give the shot of seasonal flu, which seems effective way to give access for the patients? Maybe we can discuss also this as an interesting concept. On organ transplantation, we discussed, of course, this when we introduced the directive for organ transplant, and we at least legally we secured this development because of the live donations. You really, they are very restrictively done. They should be registered. They are, I think if things are legally done in the kind of existing legal system, and which I think Romania has, and other countries, it should be secure. I mean, you can't kind of do this, underground. You need surgery department, you need, hospital. It's quite complex service. And of course, there is a criminal activities in a number of places around the globe, but this is something what Interpol and Europol, of course, is trying to trace. And every time if they find the criminal activities, of course, they try to act. But legally, we try to frame this under the directive. The point on patient groups and how we should work. I mean, it's since I am in the commission, this is what you just addressed, and think about how many meetings we spend to really find solutions. The chicken and egg question. In one hand, we don't have enough money as a public payer to give more money to European patients associations. I would love to have the budget, let's say, unlimited for NGOs, but in our health program we were able to allocate in yearly base for maximum 5 million euros a year, and we have. At the same time, the patients' organizations are growing in numbers. I don't think it's because of stimulus of industry, which many countries, many critics will say. I think the way citizens see the role as a patients and the advocacy rate is simply growing. People, they don't accepting the situation as maybe they accepted years ago, that this doctor's problem is a hospital problem. Many society people said, it's my problem, and I would like to contribute to solve my problems, my family problems, my children problems, and so on. So years ago, as a parents, we were not appearing in the schools. Now we have the boards, we have active role of parents, and somehow nobody is questioning that we are influenced as parents by special lobby of educators. We are not, and we would like to know how children are educated. So I think, but where is solution? The solution we found, and we basically tried to put the guidelines. Also, European Parliament is basically following very same approach. First, is transparent way organizations are showing the accounts, and governance. This should be clear and should be understood and be seen by everybody, by auditors if needed, and so on. We try to establish this level of the kind of how much money given by industry is a maximum that could be accepted by the co-financing from the public payer. So this is also quite critical discussion. But frankly speaking, I have only good experience with patients' organization. And I remember one very late evening, someone representing one of the organizations tells me, "Do you think I'm stupid? I'm going to lobby you because I would like you to be influenced by this or other company?" He said, "I am not going to sign my suicide certificate." So we have to also respect people. They often without extra money, with a lot of own personal time, would like to advocate for the patients and families and children. Thank you.
Good. Thank you very much indeed. Thank you for some good, frank responses. I'll try and find time to bring you in, but I'd like to get you voting. So if you've got little machines available, and if we can show the first of the systems, same before, 1 if you're against, 5 if you're for. Now there are shades in between on this, and I'm going to try and allow a couple of minutes on each of the 6 questions we've got in this section, so that if any of you wanted to make any comment, or what in the European Parliament they might call an explanation of vote, to make a comment about why you voted in a certain way that might contribute towards the formation of the roadmap as an outcome of the conference. I'm happy to bring in comments from you or any additional comments from the panel if you have any views on this. So 1, you can read that, adopt a clear European Union position, all people in Europe, etc., should have continual access to basic healthcare services. So if you have your buttons ready now, and you can press, and we'll take the first vote in 20 seconds. Thank you. Now, we've had some questions about definitions as well. So let me put you 3 right on the spot. Can and should the European Union seek to reach a common definition in the way that people have talked about? There is misunderstanding at the moment. Yes or no?
You mean on the universal access?
Yeah. I'm looking for some concrete outcomes for this conference. We've been talking about these subjects for 20 years. And it's really, really difficult for you folks in the institutions because you've got all sorts of tensions and sensitivities. So what help do you need from us, from people like me and from these people in the audience to be able to move towards solutions? Because here we have 70% of this audience says it agrees that we should do this. Well, folks, that looks fairly similar to what the institutions have already agreed in the Charter of Fundamental Rights in some respects, but we want to go a bit beyond that, don't we? So what sort of help do you people need? What would you like to be coming from a community of health organisations to support this now and then?
If I may, sorry, but you know, it's one of these value, you know, because this was also in the value of principles of healthcare, which was decided by the Council of Ministers 2005, and you know. And I remember how difficult for me when I go to the United States and I go to American university and be on the front of American students, and I use this example as our fundamental rights. And I think it's written like this. Unfortunately, you know, as usual with the abstract in the sense of the values, you know, we have tried to reach them. You know, it's difficult to reach them, but we have to do everything to get there. So I don't believe, you know, this is easy to mark. We are there, but I think, as in many, because somebody already referred today to the citizen and fundamental rights. I think Monika, you did this. I think in the citizen rights we also believe in a number of values, and I think this is one of those values we have in Europe, and I think we should agree. But okay. is a simple how to measure this. It's of course next problem.
Which came up strongly, yeah.
Yeah, I think about the value of this, we have no doubt. I don't think it's so important to reach a consensus. Okay. I think it's important, the direction and the principle behind, I think we share, okay. Basically. I will not put much on effort on definition. Okay. And I will put some specific action to move.
To move forward, take some concrete actions. Thank you, that's a helpful answer. Yes, please. I'm also wondering who the 9% is, if anybody else wants to just express perhaps why you voted. So I have the man there with his hand up in the suit and the blue tie and the white shirt, and I saw a hand down here. I will bring you both in. A couple of quick comments, and then we'll move on to the next question. Actually, we've got the microphone there, so if you'd like to go first, and the microphone will be with you for the... Yep, please, come in first. Yep, yeah. Please.
Boris, as SMSD. I had a question before the questions. Can I ask a question to the panelists?
Try me. I'll do my best.
Okay.
Go on, ask
so basically, it was to reflect on what Guido Rasi mentioned on clustering countries. And my question is both to Guido Rasi and Andrzej. How do you see this working? While we know that companies can't really price their products according to income level and severity, burden of disease, and so forth, because immediately, if you have huge price differences, you have parallel trade, arbitrage, or in any case, you have price comparisons between countries. So how do you see that working if some countries decide to create a coalition of the willing and have their own negotiation? It's never going to be in isolation, because it's part of a network of either arbitraging or price comparisons.
Guido, can you answer that in 30 seconds?
In 30 seconds.
Please.
I think that theoretically each country negotiates in isolation, but in fact everybody knows what the other is doing, first. Second, this is consistent with the fact that you cannot come up now with a European price. That's why I think clustering some common feature, whatever they are, might be a good starting point, suiting both. 31 seconds.
Perfect. Thank you very much indeed. Gentleman over here, please.
I'm Reader from Belgium, health insurance. The problem with this definition is that it contains the notion of basic healthcare. Yeah. And then you start, what is it? And it's connected to one of the questions, for instance, for the prisoners. Then you start to make a difference. What is basic and what is... And then you're away from universal. Universal means people have right to health and to healthcare. This is politically very sensitive, of course, because, for instance, in Belgium, we have the same time this political decision who says that prisoners should not longer be entitled to their sickness benefits if they have them, and at the same time, we have a political discussion of bringing back prisoners under the comprehensive health insurance. So it's double one. It shows how difficult this notion is, and therefore this is a difficult definition, because if you say yes, you have said to basic healthcare, and so what is it? So it doesn't solve the issue of universality.
Thank you very much indeed. Thank you for those comments. I'm always happy to bring you in if anybody wants to debate it. Otherwise, we'll move on to the next one. But I know we've always worked on the process of levelling up, so I think that's an important point that you've made to take into account in the roadmap about where we need to go. Can we have question 2, please, which is picking up the questions about the work to improve education understanding of some things we were hearing about in the last session, biosimilar medicines, to ensure universal access to high-quality biological treatments. Would you like to cast your votes now? Again, 1 if you disagree with that statement to be part of the roadmap. 5 if you feel strongly for it. And again, if anybody would like to comment or ask a question of the panel on that subject, I'm happy to take a minute or 2 of any comments that you might want that can be taken account in the compilation of the roadmap. Can we see the scores, please? Again, you're very positive this afternoon. Very good. You're all in positive moods. So,
too much coffee.
Something like 70. Yes, it's the stimulants in the beverages. 70% again of you strongly in favour of that. Any particular comments why you felt strongly about that? Yes, please. I wasn't able to bring you in earlier, so I'm happy to do now. We'll get a microphone to this man with a red shirt, tie on, please.
Yes, John Weber, Secretary General, opposing. This one is actually, we always talk around the elephant in the room, and that's actually, we want to have access to the data from the different stakeholders, that their data is going from one stakeholder to the other one. And I'm then getting in the second part, because these are actually 2 questions. I got the biosimilars medicines, and then we are again excluding, the elephant in the room. So I really want to have more emphasized here that yes, of course we do that because we are the European platform for patient organization, science and industry, but we go much deeper and we want to have the more, let's say, awareness about that we have the biobanks with the data set that everyone wants to have. We have the electronic health record with the data set that everyone has, and the personal health record and the Internet of Things. And we should actually start talking about, we need all those things together to get more medical trials, to get more SMEs and stuff like that. And I'm a little bit here waiting to access and universal health. Health is no longer healthcare. Health is well-being, aging, and stuff like that. And we should actually get more integration of the other stakeholders that are right now, again, not here. The ICT and all the others that are inside of EPOSI and actually are talking right now on another congress exactly about the same.
Yeah, thank you. Points well made. Thank you very much indeed. There's a gentleman there.
Yes,
concise if you would, please, because you spoke.
Yes, I'd just like to make comments to Guido, Rasi, regards to the EMA. I've actually taken part in the patient representative to actually partake in the EMA as to, present an argument for a particular medication. Of course, I can't. What I would like to suggest and comment on is the absence of the loss of, the fact that there's only one patient representative, whereas with regards to people representing a whole company, and I can't just explain from my experience, even from other people, other peer reps, there was a dozen. So basically, it was just one patient representative, myself, and there was a board of a dozen, 2 consultants on their behalf. 2 consultants on behalf of the EMA. Maybe perhaps in order to enhance this cooperation, to actually have more patient representatives right there in that moment, or at least alternatively have a strategy where patients can actually send their, through the NGO, they actually make their notes. They say, look, okay.
Okay. Please, I ask you to be concise. So can you conclude your point now, please?
I'm trying.
Yeah.
I didn't interrupt you. Excuse me. So alternatively, either or there's a strategy where all the NGOs, they say, look, there's a person A, B, or C being nominated for this section and this session, look, what are your concerns? And that person will relay his concerns, because as you are aware, if there's too many people in the room, the whole time frame will be taken up.
Thank you for making your point. Thank you. Okay, let's move on, because I'm really getting a little bit pressed for time. I'm keen to bring as many in as I can, so I will do that. A couple of hands here, but I would be grateful if you could keep questions or comments concise so that we can be fair to everybody, please.
Thank you. My name is Elke Grote. I'm Director of Public Affairs for Sandoz Europe. I have a question with regard, it's related to this statement. So as Mr. Guido Rasi said before, it's great to see that the European Commission has established this expert group stamp on safe and timely access to medicines. I have two questions, very specific questions related to that. One is, do you foresee with the experience you now have to have a structured dialogue with the different stakeholders for this expert group? And the second question is there an aspiration to broaden the scope also for STEMP? And the reason I'm asking is because now it's very much focused on regulatory pathway challenges for new molecules, in fact, while if we look at the important role that biosimilar medicines and generic medicines and value-added medicines play in increasing access to patients, we see also quite a lot of access barriers in the different member states, not so much in the regulatory process, but more in price and reimbursement.
Thank you. Well done. Thank you very much. I know these are complex issues. I'm sorry to cut you off. While the microphone is moving to Fraser for the last question, did anybody want to answer succinctly?
I guess that to no, sorry.
No,
Any other questions?
I mean, I wanted to just thank the comment from our colleague here from Malta, because it's moving upstream for the discussion that we're having as we're calling for more partnerships and innovative governance and such as the stakeholder groups. We need to look at how we manage these in terms of accountability, in terms of contributions, in terms of how they function in the decision making. And this is a piece of work that I'm currently starting within my own program, and I'm collaborating with the observatory. So I'm very keen to continue this discussion with those of you here.
Excellent. Go forward. Fraser, please.
Yeah, thank you, Clive. I just wanted to raise some issues of what I think is missing. It's all very easy to agree on certain topics like this, but if they're just taken in isolation and others are excluded, then you're agreeing to a very limited menu. And so, for me, the point about health workforce is essential. Half of the 6 building blocks in the WHO are to do with health workforce. Yeah. And also, if it's an accessible healthcare system, and then we're talking about universal health, well, you're missing the public health dimension of that. And nobody yet has talked about the social determinants of health. Yeah. And if we're just narrowing down continuously, whilst everybody might agree, we're only capturing in our agreement a very partial and small part of what we need to address. I just wanted to highlight that right now.
Thank you. Thank you, and clearly well received that you did. Let's move on to the other questions so that you can see what the other points that are being made are in this session. Then if any others have got some concerns about things that are missed, that will help you to frame that. So, third question for you to vote on, for or against, or shades of developing common tools. This is reflecting back on the discussion we had earlier this afternoon about measuring access to healthcare, monitoring, mentioned by Guido and others during the course of today, but particularly the reference which came up earlier this afternoon on the European semester. So you can see the questioners again. You're familiar with the process now. 1 if you're strongly against that, 5 if you're strongly for it. I will go through all the questions now and conclude the voting, and then I'll give you and our panellists the chance for any concluding comments in this session, which need to conclude relatively shortly. So I'll have one concluding session. Okay, thank you for voting. If we look there, that's a strong vote again. Again, nearly 80% in terms in favour of developing common tools and that statement. So thank you for that. That's clearly noted. and a good strong rate. So question 4, if we can move to that, and we'll vote that again. So if we can have question 4 on the screen. And again, we've had 2 or 3 questions that have come up about addressing health workforce shortages and brain drain, including appropriate investment in a highly skilled workforce. I wish we had time for workshops and seminars. I'd love to ask questions if people are going to be against this sort of thing. What would you like to see? But 1 to 5, please, if you would vote now. If you can vote 1, again, if you strongly disagree that that should be part of the roadmap. 5, if you strongly agree, and points in between. Good, thank you very much. And the results flash up very quickly. And again, getting even stronger. You are focused, obviously that was a strong point that you want to be focused on in the outcomes of the conference. So that's number 4. Okay, on number 5, if we put that up on the screen, that moves towards those of us who have particular interest in looking at the innovation that Guido in particular mentioned, addressing unmet needs, particularly looking at the research programs of the European Union, how that can be harnessed and used, and suggesting some particular areas. So if you would vote on that, if you'd again like to see that in the roadmap, how strongly you feel about this. And again, the choices are the same. 1, if you disagree with that. And 5, if you are strongly in favour of seeing all our friends in DG Research fund these sort of activities and offer opportunities for partnerships and innovations through that method. So thank you again for your vote. That's another area, and let's see what you think about that. Again, showing the trend of today. Interesting that very, very rarely is there absolute unanimity or nobody at all against it, showing that there is a range of views here, which is why I'm glad people are expressing that, but strongly in favour. And number 6, if we can move to the 6th and final question, promoting access to accurate, objective, unbiased, scientifically up-to-date information. No challenge there then, folks. On all aspects of health. So, if you feel strongly that that should be included in the roadmap, again, same approach for the last time, last chance to vote in this session, and then we'll have a final wrap-up for a couple of minutes. And I'll give our good friends on the panel a chance for any concluding comments. And so, as we hear the exciting last result that's coming through from the afternoon session now. So again, a very strong vote there in favour. Thank you. 4 out of 5 in favour of that being taken forward. So thank you very much indeed. Now, having seen all of the proposals in this section, and obviously Catherine and others will be having another section following this, there's more to come yet. Is there anything that anybody particularly has a burning point that they wish to make? Either you strongly agree or disagree. Okay. We'll take Stephen, we'll take the woman in the fuchsia top, I think, and the man from Malta, I believe, sir.
Thank you, Clive. Stephen Gordon, European Central Council of Homeopaths, and EuroCam, which represents a range of patient and providers of complementary medicine. I particularly welcome the last 2 questions because it really does raise the whole issue about, we were talking about access to healthcare, but access to what? And like the conversations have been today, they keep coming back to the biopharma model of care delivery, and very little is discussed about other forms of care. And 1 in 4 members of the European population use 1 or more forms of complementary medicine in their care, but this is never reflected in these conferences. It is never reflected in these discussions. So I welcome those last 2 points because I believe that these systems of care have a role to play, particularly when we're facing things like antimicrobial resistance, for example. And I welcome the fact that last year WHO introduced a strategy document for complementary medicine in which they recommended that health systems integrate various aspects of complementary medicine to their system. So my question is really, do the panel see a role for these things in a future European healthcare? Thank you.
Time is against us, Stephen. I can't promise we can get lengthy answers, but it's just a chance to make any last points if you'd like to. But thank you for that. Yes, please, the two speakers.
Yeah, thank you very much. My name is Elizabeth Kuiper, and I'm representing FPA, so one of the organizers of this conference. I actually wanted to call on the European Commission as the last remark for this panel, because over the last 1.5 hours, we have been discussing a lot of elements regarding accessible healthcare systems. And I was especially very happy with your excellent presentation, where you basically showed that there's a clear legal basis for the European Commission when it comes to acting on healthcare systems. And therefore, I find it interesting that over the last couple of months or the last 2 years, when we've been following discussions about initiatives from member states on access and pricing, the Commission is quite careful in stressing the competence of member states. And of course, I can understand that very much, given the current Commission and the current context in the European Union. But I would like to call on you, given the fact that you showed yourself that there is a clear legal basis to act for the Commission when it comes to healthcare systems and access. So I would say that it's also an important remark to take into account when we speak about access and healthcare systems. Thank you.
Thank you very much for that. Well done. Perfect.
Not about mental health this time, migrant health. You were provoked by the colleague at the back there about migrant health. I think it's one of the emerging vulnerables that are coming through Europe. This is coming from Malta, where we are facing the brunt of migrants, asylum seekers. Other people are facing the brunt of displaced persons from conflict in the Middle East and what's happened in the Ukraine, etc., etc. And this is an issue which will not go away. And these are the new vulnerable amongst us, and we need some particular focus on them and their rights. Thank you.
Thank you all very much indeed for a very rich number of comments and questions. If I can close just by coming back to our panel, each of you, if you would, succinctly as you're able to, either pick up anything you've just heard or any takeaway messages that you'd like to leave this audience before we conclude this session. Andrzej first.
Maybe I can start because, you know, the question was very, very precise question, and 2 questions about the stamp and the work of expert groups. You know, all documents are available on the website. So far in the kind of scope of work and the way of working, we agreed that we start from the regulatory part, but also we would like to have dialogue with stakeholders, of course, including industry. We didn't define, you know, which kind of industry, so you also are welcome to bring your concern. But at the same time, we would like to link to the HTA. So far, you know, we try not to go to the pricing reimbursement, because it can lead me to the next question, which was asked, you know, where is the Commission position and how we are positioning ourselves in this journey. It's a quite tricky question. You know, this debate as many debates in Europe started from basically no. Then we have the phase, you know, what to do. Yes and no, yes and no. As Jo said today, in a few days, in the 15th of July, we'll discuss in the Council senior official group, you know, way forward. So we are in most on yes. We don't know yet, you know, how, but this is the dynamic of this process. I mean, it's my 10 years in the Commission, and I learned that, you know, you have to be patient. You know, when I arrived as a former Vice Minister of Health, I knew I can do things in months' time. Here, of course, you have to be more careful, and I think dynamic is there. So let's see. I mean, I don't like to predict, you know, the next step, because it's really still the competence of member states, and we don't pretend that we are there. Maybe last point, comment on this, but also I should confess that at the same time we are there, because, for example, in the process of European semester, we, of course, and especially with some countries, we were quite active, you know, trying to assess the situation. And, you know, not mention countries, but few, and them really deeply. We try to get to the way the pricing and market is built. On the other issue, because I should answer, the complementary medicine, you know, again, this is not us, Commission, which is in this field. This is more for member states, but at the same time, at least in the products like homeopathic medicines or herbal medicines, we try to do our part, which is in the legislation, and the EMA is working on this concerning herbal medicine. so this is our competence. It's very difficult for us to do more. We did invest some money through research program to understand better the scope of this treatment and what is on the market. And last point on migrant health, it's important point. These people arrive to Europe, they become citizen, or at least people in the European territory, and then we can't forget about their existence, and we have to find a way to deal with the problem.
Andrzej, thank you very much indeed. Lots of questions there. Guido, please, any conclusions?
I have just to comment. I understood today that we are on the right track for many things, a huge room for improvement of many. I take some lesson that any good idea bears some side effect, as I learned, and room for improvement. We think we are at a good level for patient engagement, still a lot of work to do. And thank you for the input. I will work on it.
Thank you very much indeed. Monika, thank you for jumping into the WHO hot seat. Appreciate it.
So just two comments from me to close. I want to go back to 2 points that Fraser made. And the first one on the health workforce, which we've touched on, and I think everybody acknowledged in not enough detail. But when we talk about our healthcare systems, when we talk about the sector, of course, we're talking about the people as much as we are the processes and the products. And this is for any change process addressing the workforce in its training, but also in terms of what we're asking it to do in our new challenges and the new changes that are coming in externally. And the second but linked component of that is the social determinants, because when we look at people who have the least access to healthcare, if I put it in that way, the people with the greatest barriers and the greatest challenges, they're also the individuals that we see in our societies that have the greatest challenges from the perspective of equity, poverty, and social determinants, and exclusion, and particularly exclusion. So these two, when taking these discussions forward, we need to go beyond our silo. We need to go beyond the discussion that we're having as a health sector, because both of those issues, both the health workforce, the social determinants, and the equity, we can't tackle alone. It's not just us that own all those levers. And so to make our health systems fully accessible and universal, we need to also engage other levels of government and other actors and use the tools that we have to do so, and develop new ones.
Very well said. Good. Thank you. So thank you very much. Your next round of stimulating beverages are waiting outside. A short break again, but very good session to follow. So I hope you'll all come back in another 20 minutes or so. Thank you to the organisers for inviting us. Can I ask you just to show your appreciation, all of you, and say thank you to our panellists for being up there this morning. Thank you all very much indeed. Thank you.